Okay, we're going to move on to presentation by Dr. Lionel Bercovitch, who is a professor of dermatology and I think director of pediatric dermatology at Brown University. Lionel has worked with PXE since actually the day that my kids were diagnosed, because he is the guy who diagnosed them. So he's the one who started us on this path, so to speak, and then he might say we started him on this path. It turned out we were neighbors at the time by some cosmic coincidence, and we have been joined at the hip doing PXE ever since, all these years. So Lionel, I'm going to turn it over to you.
Sure. Thank you, Sharon. I'm able to share my screen?
Yes. Yep.
Okay. Let me just quickly find the yeah, let me just go back here. I saw the title on Yoni's slide, PXE in the skin. I said, Yoni, you're giving my talk.
Yeah.
But that was just, I think that was just a segue into the part of the lecture we actually saw. I think if we left it a few more minutes, he would have given the whole talk. So I'm going to talk a bit about PXE and the skin. As you know, PXE, skin involvement is often the first sign that patients have of PXE, and it's certainly the most visible. And it's the one that gave the disease its name. Xanthoma means a cholesterol deposit, and xanthos is, I think, Greek for yellow. And they were called pseudoxanthomas because they're not truly xanthomas. They're not made up of cholesterol deposits or fat deposits in the skin. They're made up of dystrophic or abnormal elastic tissue. But we'll go over this in a few minutes. So PXE, the diagnostic criteria for PXE that are more or less operationally in use now are the presence of two major skin criteria, one major ocular criterion, or two pathogenic mutations or variants of ABCC6. So basically, if you have two pathogenic allelic mutations, meaning on separate chromosomes of ABCC6, you really have PXE, but you may or may not have any signs or symptoms depending on your age. Clinically, before the availability of genetic testing, skin and ocular criteria were how the diagnosis was made. And basically, the major skin criteria are either the presence of typical skin lesions in typical locations, and I'll show you those in a minute, and the presence of typical microscopic changes on biopsy, and I'll show you those as well. The ocular criteria were either peau d'orange in younger individuals or angioid streaks. So basically, if you have two pathogenic mutations, that means disease-causing mutations or mutations that have been shown to cause disease or predicted to cause disease, plus one or either eye or skin findings, then I think you can make the diagnosis of PXE. And in actual fact, virtually every patient beyond the age of 40 has eye findings. And I'll tell you later on why that's important in terms of making diagnosis. So dermatologists have their own language. When we describe skin lesions, we use terminology that helps us know what the other person is talking about. Bumps, pimples, things like that. We don't really use those terms because they're not really precise enough to really determine exactly what the lesions are. So the primary lesion, we speak of primary lesions in dermatology. We mean lesions that are not picked off or scratched or result of like a pustule bursting or a blister bursting. They're actually how the lesions start, and they're the ones that are usually diagnostic. And the primary lesion is a papule, and that basically, to use lay terminology, would be a bump less than 5 millimeters in diameter. And for those of you who are not in Canada or Europe or the rest of the world, but in the United States, 5 millimeters is about 1/5 of an inch, so it's pretty small. Papules, and actually in the definition now is actually, I should say, has been expanded. It's actually up to 1 centimeter. When you get beyond 1 centimeter, which is 2/5 of an inch, the raised lesions are referred to as plaques. In more advanced stages, the skin becomes lax and forms loose folds. So the papules can be oval, they can be irregular in shape, they can be rhomboid in shape, they can be circular. They tend to be somewhat yellowish or yellowish orange or grayish yellow in color, depending on background skin color and the depth of the lesions. And it may give the skin an unwashed or cobblestone look. Sometimes people have used the term chicken skin. I don't like the term, or plucked chicken skin. I think it's a pejorative term, and we don't use the term, but you've probably heard it, and some you may even use that term to describe the appearance. But it really doesn't look like a plucked chicken. And a plucked chicken, the feathers are pulled out, and of course the feathers are our equivalent of hairs, and these lesions have nothing to do with hair follicles. So changes can be pretty subtle. There's an arrow here pointing to just one of these papules. Again, if your vision if you have low vision, or your monitor is not very bright, it may be hard to see. Here's another individual. Again, these here are, in this case here, they're somewhat yellowish. In this case here, they're somewhat skin colored or whitish. Here they have a more whitish or skin colored appearance as well. They usually start at the back of the neck, or the lateral or the aspect of the neck. Now here you can see this kind of yellowish bumpy change, but you can see now the skin is becoming kind of somewhat lax or redundant. And that's a more advanced stage of PXE skin changes. But you can have these changes and have minimal eye changes. I mean, and in fact, one thing that Sharon pointed out is that there really is no correlation between the genetic mutation and the actual findings. So we have families where one individual has had multiple retinal bleeds, and other individuals have had virtually no eye symptoms except for the presence of angioid streaks. In some families where the skin symptoms or the skin findings are very marked, and other individuals have very little skin findings. So it can be very variable even within a family. This is the underarm. Again, the skin findings look much the same. For some people, these findings in the underarm may be the only findings, or maybe very mild. Here are so-called plaques. These are a little larger than the little bumps. Where my cursor is, you can see little papules. Where my cursor is now, these are more often to be described as plaques. But then you can get extreme laxity of the underarm. There's an example of where the actual lesions are really not all that noticeable, but the laxity is very prominent. We'll talk a little bit about how that can be managed and treated. Here's an example. This is the crease in front of the arm. We call this the antecubital fossa. And you can see the linear array of little yellowish white bumps. Here's another example where the changes almost look net-like, but again, they have a somewhat yellowish appearance. So the inside of the lip is actually a mucous membrane. We call it the mucosa. But when you biopsy it or look at it under the microscope, it looks very much like skin. It has the same kind of layers, except instead of being referred to as the epidermis and the dermis, we refer to it as the mucosa and the submucosa. And so you can see the same changes inside the lip. They're little yellowish bumps. These can be seen inside you can sometimes see these on endoscopy, where, when you gastroscopy or colonoscopy, or it can be seen around the vagina, can be seen in the anus. So these changes can be seen in anywhere you have this kind of structure. Years ago, Mark Lebwall at Mount Sinai Hospital in New York, who was one of the clinical pioneers in PXE, very astutely noticed that many women, particularly with PXE, had these oblique chin creases. These are changes we often will see with aging and older individuals, but these patients would often have this in their 30s, and we don't really know why. We've tried biopsying these and not shown any changes that are typical for PXE. Here's another example. We did a survey, one of the first early PXE International patient meetings, and took a lot of pictures, and no question this was a fairly common sign. I think I should put this on slide view. I think it'll be actually easier to show the pictures. That's better. Yeah, I'm sorry. Probably it was hard to see some things before. So to make a diagnosis, we do a skin biopsy. Most of you probably had one in the past, although it's not always necessary to do one, especially if it's, if you've got a family member with PXE and you start developing similar changes, it's highly unlikely there's another cause for it. But the biopsy is done with something called a biopsy punch. It takes a 3 or 4 millimeter piece of skin with a little thing that looks like an apple core, and you get a little cylindrical piece, like a specimen like this, which is then submitted to a pathology lab, and then it's sometimes closed with a stitch, sometimes not. And generally heals with just a very small scar. And this is a simple, painless technique. It's done under local anesthesia, and very helpful in making a diagnosis or ruling out a diagnosis. So what do we look for? Well, if you can imagine the cylinder of skin is mounted in paraffin or in wax, and then it's put through what's called a microtome. If you've ever been to the deli and watched how they slice meat, have bologna or salami or corned beef, that's basically how the skin specimens are handled. And little thin slivers of paraffin embedded formalin pickled or fixed skin are placed on slides, and then stains are applied to it. And these stains are taken up differently by different types of tissue in the skin. And the classic one is something called H&E, or hematoxylin and eosin. And this gives you this pink and purple and blue colors. If you look up here, this sort of purplish undulating layer is called the epidermis. This is the very surface layer. This pink layer overlies the subcutaneous fat, and it's called the dermis. And the changes that occur in PXE are actually fairly low in the dermis, which is one of the reasons why it's kind of hard to treat with laser. You can't just sort of, shave off or plane off the surface of the skin and expect that it's going to regenerate and then cover up and get rid of the abnormal tissue, because it's fairly deep. And you see these sort of, well, it's hard to really see here, but we've got it magnified, these kind of irregular yellowish or pinkish purple clumped elastic fibers. There are special stains for various tissues, and there's one called the Weigert stain, and there's a few others, but these generally stain elastic tissue a different color, so it's easier to see. And you can see these kind of frayed, kind of clumped, irregular elastic fibers. Usually they're very fine, very thin, and this is the abnormal elastic tissue. And one of the characteristics of PXE is that the altered elastic fibers calcify, and that's the result of we think, of absence of or diminished levels of pyrophosphate in the circulation or in tissue fluids, which is an inhibitor of what we call ectopic calcification. We call it ectopic because these tissues don't normally calcify or mineralize. It's not just calcium, there are other minerals too. This stain has an affinity for calcium, so it's called alizarin red, but it's not important, the name of it. But what you can see here is the calcified elastic tissue is fairly deep in the dermis. If you look up here, the green layer on the surface, that's undulating layer, is actually the epidermis. And this kind of violet, this turquoise layer on top of it is more superficial layers of dermis. This is just a different stain called the von Casa, which you may have heard of in some of the talks. It just stains calcium black. And you can see how irregular and clumped these elastic fibers are. So there are things that look like PXE, but aren't PXE. I mean, when I give similar lectures to our dermatology residents or to dermatology meetings, I go to it in much more detail. But I'm not going to do that here, because we're not trying to train dermatologists. Most of you have already had the diagnosis of PXE made, but I'm going to show you an example of something that looks like a duck, but it doesn't quack like a duck and doesn't act like a duck, so it isn't a duck. And that is a condition called fibroelastic papulosis. And it goes by other names as well. And we haven't had one come through PXE International lately, but in past years, we've had people registered in PXE International who have been diagnosed by their physicians as having PXE, usually diagnosed in their 60s or 50s or 70s, who, if you looked at their skin and looked at their neck, they got PXE. It looks exactly like PXE. I mean, I can understand why a dermatologist would come to this conclusion. And it looks, I mean, you really would have a hard time telling the difference. It even affects the same areas of skin. It's called elastolytic, means destruction of elastic tissue. And what happens in this condition is that you actually get lysis, or destruction of elastic fibers very high up in the dermis. It looks just like, as I said, it looks just like PXE. The mean age of these individuals is 62 years. And again, it affects far more females than males. But when you biopsy it, there's no mineralization on light microscopy. There's no mineralization on special stains. These patients have no eye or vascular findings. And if they do have vascular findings or claudication, it's completely coincidental. Angioid streaks are pretty specific for PXE. It's not the only disease that's been associated with it, but it's certainly, far and away the most common cause of angioid streaks. These patients have no angioid streaks, and they're extremely grateful to find out that really what they have is just I guess it's a sort of an aging change, but it's not a typical aging change. And in actual fact, we really don't have a great treatment for this one either. This is not genetic. There's no known causative genetic mutation in these patients. So what we found, and what Kat showed you, is that females tend to develop visible signs of PXE at an earlier age than males, and therefore females are more likely to be diagnosed by dermatologists. Males are more likely to be diagnosed by an ophthalmologist than a dermatologist in terms of their early registry statistics. That may be different now, but that certainly has been the case in the past. Hopefully you get diagnosed before you end up with a retinal hemorrhage or loss of vision loss. There has only been one study done by Ludovic Martin, who's one of our PXE International colleagues in Angers, France, who runs a PXE Center of Excellence there in their institution. And they did a study, and they found there was a correlation between the number of affected areas in the skin and severe cardiovascular events or ophthalmological complications, but that hasn't been borne out in other studies, so it's hard to really know. Again, the common denominator in some of these studies may be the fact that as you age, the number of affected areas increases, and of course, as you age, cardiovascular comorbidities tend to increase as well. So that underlying atherosclerosis that might have been there even had you not had PXE maybe have an additive effect. So we generally don't. I mean, it may be an interesting epidemiological fact, but it's not. For the most, that doesn't. One thing we learn in epidemiology, that finding an association does not mean cause and effect. So that's all fine and dandy. You've all had a diagnosis made. What many of you want to know is, well, how can I make it look better, or what can I do about it? Surprisingly, considering how many people have PXE, we have, something like 4,800 in our registry. You think, considering the hundreds and hundreds of papers that have been written about PXE, and more recently, a lot of papers about animal model treatment and in human clinical trials and so forth, that we would be further along the way in terms of surgical and laser management of the skin findings. But there actually you can count on one hand the number of publications, and actually when you do the literature search, most of the publications are more than 30 years old. There are only 2 or 3 since 1990, and they're really not in high quality journals, and there are no real case series to give you any kind of idea about wound healing, about success rates, recurrence rates, and so forth. So generally, when you have lax skin, you can remove the excess skin and suture the skin together, and that's sometimes done on the neck, or you can try to tighten the loose tissue and place the scar in an inconspicuous place. So you can remove excessive or lax skin or redundant skin in the neck. You can do it in the groin. You can do it in the axilla. It's a bit harder to hide the scar in the groin than it is in the underarm. You can tighten the loose skin and place the scar in an inconspicuous place. So sometimes when abdominoplasties are done, the scar is placed in the very lower abdomen, so it doesn't show wearing a two-piece bathing suit, or you can place it under the breast. You'd sort of you remove excess skin and tighten the abdominal skin the way you would a sheet making a bed, and then hide it under the breast. Neck and facelifts, as you know, the scars are often hidden behind the ear, so they don't show. You can have brachioplasties where excessive skin is taken off under the arm, and then the scar is hidden in the back of the arm, or in the back of the underarm, or what's called a thighplasty, which is, and a lot of the surgical techniques for things like brachioplasties, which are arm lifts, and thighplasties, or thigh lifts, and abdominoplasties come from the obesity literature. A lot of patients who've had obesity surgery or have lost tremendous amounts of weight through dieting end up having a lot of excess skin that's really quite unsightly, and it's really amazing the things that have been done in these patients to really improve the appearance of the skin. So some of those techniques are applicable to lax skin and PXE, which fortunately is never quite as severe as those who had massive weight loss after obesity. Generally, it's recommended that patients who undergo surgery, most of this is done under general anesthesia, just because of the extent of the amount of skin that has to be removed. It's a little bit impractical to administer that much local anesthesia, although sometimes they can do it under what's called tumescent anesthesia, where the anesthetic is diluted, so larger volumes can be given and still get good anesthesia. But most patients should have a cardiac evaluation, because the last thing the surgeon wants is a surprise on the operating table, or that you would want for that matter. Smoking tends to impair wound healing. Of course, smoking is a no-no in PXE because it greatly increases the risk of peripheral vascular disease and atherosclerosis, and is a risk factor for coronary artery disease. But it may impair wound healing, and most plastic surgeons will generally avoid doing cosmetic procedures on active smokers for that reason. So plastic surgery can improve the appearance of lax skin by tightening it, but it doesn't really have any effect on the underlying process. So you can remove the skin with the cobblestoning, but eventually, it can recur in the skin that's left behind. One of the reasons why in the neck, you don't want to just do simply a lift and just stretch the skin and remove some skin. You want to make sure you actually remove the abnormal looking skin, not just lax skin. And so in facelifts, again, you can tighten the skin, but it still continues, the skin that's left behind continues to age, and eventually laxity may recur. So it's not uncommon for example, after facelifts to have a repeat procedure 10 or 12 years later, and the same with surgery for lax skin and PXE. At least in the few published cases and the ones we hear about, the skin in PXE seems to heal uneventfully. There's no reason to suspect that the skin wouldn't heal. There's nothing about the abnormal elastic tissue that impedes scar formation. That doesn't tend to have any higher risk of keloid formation or hypertrophic or thickened scar formation. The elastic tissue is not generally involved in the development of those kind of scars. And most patients seem to be satisfied with the outcome. So here's an example of somebody, this is a South African patient, I believe, who had neck surgery done, and you can see there's there's a very faint scar. And one thing about sun damaged skin or skin with elastic tissue damage, it tends to hide scars very well. One thing that those of us who do skin cancer surgery, and now that I do primarily pediatric dermatology, I don't do that much of it anymore. But the one thing I used to love about doing surgery on the facial surgery on patients in their 80s and 90s or even mid to late 70s is that scars are hidden beautifully in sun damaged skin. They often, you can't even see them afterwards. Whereas when you do the same thing in somebody who's younger, the scars tend to be much more visible. Now, eventually, some of that pseudoxanthomatous change may recur in the skin, and the skin may become more lax again. But this is a good cosmetic result. This is somebody who's had. This is a paper from Spain, or sorry, from Italy, I should say. This patient had lax skin secondary to PXE and underwent a brachioplasty or arm lift. And the scar actually here is hidden under the arm and the back of the arm. I mean, you can sort of barely see the scar here. It's not something that most people would really notice. It's not that conspicuous. It's certainly not nearly as conspicuous as the way the skin looked beforehand. So a good plastic surgeon would who's had experience dealing with these procedures in patients who've lost a lot of weight would know what to do in a situation of PXE. So laser resurfacing is another technique that's used in sun damaged skin. In general, in sun damaged skin, the changes are what we call solar elastosis, where you get clumping and degeneration of the elastic tissue. Tends to be very superficial. It can often mimic PXE, although it looks different the way in the pattern it actually it takes on the skin. But you can actually make sun damaged skin look like a newborn baby skin, and it doesn't work quite as well in PXE because the changes in PXE are much deeper in the skin. So there are two types of laser resurfacing. One is called ablative, where you basically heat up and remove the surface layer of the skin, and the other one is non-ablative. And the lasers that are used now are called fractional lasers or fraxels, and these lasers tend to puncture little holes in the skin and stimulate the healing response from the dermis outward. But the response here is limited by the depth of the elastic tissue abnormality and persistence of of course, the molecular defect is still there. The skin still has the ABCC6 pathogenic mutation. So there really has been virtually no published experience. There are probably a few people who've had this done. And if any of you have had it done or are satisfied with the result, I'd be interested in hearing what's been done. I know it's been done for the PXE mimicker I've shown you with decent results, but the changes there are much more superficial. So that's basically all I have to say, but I'm happy to hear questions and do my best to answer the questions.
Great, thanks, Lionel. Okay. Maybe you could take your slides down so people can see each other and you. And so the floor is open for questions. Any questions?
I'd be curious to know if anybody here has had surgery for their skin changes and where it was done and what was done and how good the results were.
Nobody.
Interesting.
Mm-hmm.
I mean, go ahead.
Linda and maybe Hope, I think, are raising their hands. You can unmute if you'd like. And if you can't unmute, unfortunately, the host can no longer do that. Go ahead, Linda.
Okay.
And Hope.
I had both eyes done and
both eyelids.
Oh, we're eyelids.
Upper
eyelids.
And lower. Mm-hmm. And that was 2010. And I had a picture taken in 2005. And I compare those two pictures. And it looked like I was so deformed in 2005, and no one ever noticed. I didn't even notice. And the picture is so different. It's unbelievable.
Yeah. Well,
now,
so Bleff, yeah, Bleff,
22 years ago now. I mean, 12 years. Well, what is it? Yeah, 12 years ago.
what you had done, what you had done was called a blepharoplasty, or removal of eyelid skin. And
exactly.
Just so people understand, in that situation, you basically remove the redundant well, of course, Wayne can discuss that too, but you remove the redundant skin and then suture the remaining skin together. You tighten the upper eyelid. PXE doesn't really affect the eyelid, so it's a very common aging change, and some people are very prone to this. But the technique is really, I mean, the techniques for removing the redundant skin in PXE are very similar, except you're dealing with much larger areas of skin. It's a much more difficult procedure.
Right. And I remember that for this eye, the doctor, it was the stitches, the internal stitches, I guess, had to be so tight because of the PXE skin. And boy, that was the only problem I ever had, which wasn't really a problem at all. That every now and again I can still feel that little pinch there from the skin, but I'm thrilled that I was able to do it. I was absolutely thrilled. So I don't know. I'm getting really old now, so I don't know if I'm going to do any more. But
well, welcome to our world.
How about a hope, and then we have a bunch of comments in the chat.
Thank you.
Hello, Sharon. I was wondering whether there were any difference in the results on black skin. I know that my skin goes into keloids quite easily. And as I've got older, my neck and arms has been more visibly affected by PXE. The strange thing is it hasn't affected my face. And I just used to have nightmares about this thing just coming up onto my face. From the time I was 11, it manifested itself. And so I was wondering if there was any difference. Is it worth the risk, or are you going to make something worse, you know?
So I don't think you have to worry about the skin findings coming on your face. It generally does not affect facial skin. Somebody here made I'll come to it, about the chin creases are not actually due to PXE itself. If you're a keloid former, I think you probably would be best not taking a chance on having surgery done on the skin, just because there's no guarantee you wouldn't get keloid type scarring elsewhere. Facial skin, of course, is a different story. Keloid formation on the face tends to be quite unusual for most patients. See it sometimes with acne scarring, but it's not very common with facial surgery. Somebody made a comment here about having had fillers for chin creases, and asked whether this needs to be done about annually. So the answer is yes, fillers do need to be done every 6 to 12 months, or depending on when the effect wears off. Most fillers are substances that are injected into the skin that are incorporated into the dermis. Most of them are made of things like hyaluronic acid, for example. Again, because of the nature of my pediatric practice, I don't get any demand for fillers. So I have no experience. I can't give you advice about which fillers are better. There are fillers that work better in certain locations or are better suited to certain types of changes on the skin, and somebody who does a lot of this type of cosmetic procedure would be a much better person to advise you. But if the issue is deep creases or puffing out areas that are sort of hollowed out or with deep, then fillers are the answer. For things like fine wrinkles, Botox would be the answer. But again, I don't think that would be, Botox is not going to be an answer for the kind of changes you get in PXE skin. Someone is, filler was supposed to last 24 months. My feeling is that my improvement was noticeable, but for 18 months. So would PXE potentially make collagen-based fillers work, but less successfully? 24 months is probably the outside limit for effectiveness. 18 months would be, even that would be more than most of these last. So I think that that's a normal effect. I don't think the presence of PXE would really, you're not really using fillers in areas that have PXE. Most times fillers are given for facial changes, and generally you don't find PXE lesional skin on the face. So generally that is not an issue. Most of the changes that occur on the face are generally related to solar damage or normal aging, or sun damage and normal aging.
So question for you, Lionel, about laser lipolysis, lipolysis.
All right, so lipolysis means destruction of subcutaneous fat. So it's the most common technique used is actually not laser, but cryotherapy or cryosurgical lipolysis. That would be, as far as I'm not, again, there's no published data on this, but I don't see any reason why that would be a problem. You're really aiming it at the subcutaneous fat tissue, not at the dermis. So.
And would you consider it a treatment for PXE if that's why it's being done?
No. It's really to remove. It's not a technique for weight loss either. It's used for treating love handles and things of that nature. It's not a it has no, and again, it's not the sort of thing you would probably use. I do know one patient who did try to have it done for lax axillary skin, but the result was not, it was not effective.
Okay. All right. Well, we're going to move on to the next talk. Thanks, Lionel, for always being with us and every year giving us your expertise. Really very useful.